Professor Dirk Westermann. He'll present the study Accurate and Rapid Diagnosis of Myocardial Infarction using a high-sensitive troponin 1-hour algorithm. Please.
Dear ladies and gentlemen, good morning. Hope you have some ink left. It's an honor to give our presentation entitled Accurate and Rapid Diagnosis of Myocardial Infarction using a high-sensitivity Troponin I 1-hour algorithm, and we aim to diagnose or exclude myocardial infarction faster than recommended by the guidelines. The background: there's clinical need to rapidly and safely rule in, so diagnose or rule out, exclude acute myocardial infarction in patients with acute chest pain in order to 1, initiate fast evidence-based treatment for patients with myocardial infarction, and 2, limit overuse of scarce medical resources in the emergency room, discharging patients without acute cardiac conditions, and we doctor all know it can get pretty busy in those emergency rooms today. Guidelines recommend measuring high-sensitivity assay troponins directly after admission and after a delay of 3 hours, detecting elevated levels based on the 99th percentile of that specific assay, together with the rise or fall of troponin. Recent studies, for example, but not exclusively, the ADAPT and APACE cohort challenge current guidelines with intervals shorter than the suggested 3 hours. We aim to investigate the application of high-sensitivity assay Troponin I for a rapid 1-hour rule-out and rule-in compared to a 3 hours approach, and B, to test a lower and more sensitive cutoff value compared to the 99th percentile and the biomarkers in acute cardiovascular care, the BAC cohort, investigating 1,045 patients with acute chest pain. This is the study design. Clinically, we diagnosed non-ST elevation myocardial infarction based on the EC guidelines. We measured high-sensitivity troponin T, another troponin assay, directly at admission and after a delay of 3 hours, integrating clinical judgment, imaging, and ECG to establish the final diagnosis and STEMI versus no MI. For study purposes, we measured HSTNI, another troponin I assay, directly after admission and already after 1 hour, so not waiting for 3 hours, but already after 1 hour. For comparison reasons, we also measured troponin I after 3 hours. The presented algorithm do not integrate any additional clinical information yet. Study flow is, we calculated the best performing cutoff, we applied it, we validate our results in independent cohorts, and then we applicate the cutoff in the general population utilizing a cohort of 75,000 individuals of the general population. These are actually the baseline data of our cohort. We identified 184 patients with non-ST elevation myocardial infarction. Those were compared to 793 non-acute myocardial infarction patients. Importantly, we excluded STEMI patients because STEMI is an ECG-based and not a lab-based diagnosis. Briefly, STEMI patients were, as expected, older and had more cardiovascular risk factors compared to the no AMI group. We then defined the best performing cutoff to rule out myocardial infarction. We deemed the cutoff to be optimal when it had the highest negative predicted value, lowest number of false negative patients, so patients who would have been discharged with the wrong diagnosis, and the cutoff should be about the 10% coefficient of variation, which is 5.2 in this assay. And this coefficient is a very important marker of assay precision. Therefore, we deemed the cutoff 6 nanogram per liter as optimal. This is, as you can see, way lower than the recently suggested 99th percentile, which is 27 for this specific assay. We applied that cutoff in our STEMI rule-out. So we ruled out non-ST elevation myocardial infarction when troponin I was below 6 directly at admission and after 1 hour. This resulted in 402 patients out of the 1,045 patients that could be discharged directly after 1 hour. The negative predicted value was very high after 1 hour, with 99.7 for all NSTEMI type 1s, in view of the third definition of myocardial infarction, and 99% for all NSTEMI patients. This was statistically not different than waiting for 3 hours the 3-hour NPV was 199.5. Again, 1 hour performed as good as 3 hours. We then compared the 6 nanogram per liter cutoff to the recently used 99th percentile, and when we would have used the 99th percentile, NPV would have been lower, 98.4 and 99.1 for NSTEMI type 1, significantly lower than the 6 nanogram per liter cutoffs. Therefore, we would have missed patients with myocardial infarction and would have discharged them when we would have applied the 99th percentile. This is actually the calculated best rule-in algorithm. We deemed a patient to have an NSTEMI when the troponin I after 1 hour was above 6 nanogram per liter, together with a delta of an absolute 12 nanogram per liter compared to the admission value. So patient needed to have a higher value than 6 and a delta of 12 compared to the admission. This resulted in a high positive predicted value after 1 hour, again, not statistically different compared to 3 hours, so there was no way to wait for 3 hours. We validated our algorithm and cutoff in 2 independent cohorts of patients with recent onset chest pain suggested of acute myocardial infarction. Those 2 cohorts included 4,009 additional patients. The first cohort was the APACE cohort, a European cohort, also utilizing a 1-hour algorithm. Therefore, we could directly apply our rules to that cohort. We validated our results with a very high a negative predicted value of 99.2 for rule out and a positive predicted value for 80% for making the diagnosis NSTEMI. So a validation of our results. The Australian ADAPT cohort is a little bit different. It utilizes a 2-hour approach, not waiting for 1 hour, but for 2 hours. Still a valid cohort, since it waits shorter than the suggested ESC guidelines. And in that cohort, NPV was high with 99.7 for all NSTEMI patients also, so again, a good validation for our algorithm and rule out. Follow-up mortality is highly important for patients being ruled out and then discharged home without acute cardiac care. Therefore, we documented the 6 months mortality in the BAC cohort. 3 patients were lost to follow-up after a median of 183 days. Ruled out patients, so patients with troponin I values below 6 at admission and after 1 hour, had very low follow-up mortality. Patients ruled in had higher follow-up mortality, and interestingly, importantly, those patients now labeled as gray zone patients, so they did not fit in the NSTEMI rule in or the rule out group, so they had elevated troponin I levels without the sufficient dynamics to be ruled in, had the highest mortality. Therefore, it's of utmost importance to further evaluate those patients. Those can't be discharged immediately and probably need specific medical treatment. This also implies that elevated troponin I values imply cardiovascular risk. When we would have applied the 99th percentile and would have discharged patients based on that cutoff, we would have documented 12 deadly events compared to only 3 with our more sensitive cutoff. So again, 6 performed better than 27. This is the last slide. We now wanted to imply the clinical relevance in daily life. Therefore, we utilized the biomarker cohort. We measured in roughly 75,000 individuals from the general population troponin I. Those individuals had no prevalent cardiovascular disease, and we followed them up for cardiovascular mortality. Again, a cutoff of individuals with troponin I values below 6 had lower mortality compared to individuals with troponin I values below 27 only. This was true for 1-year follow-up and 5-year follow-up. Therefore, we'd like to conclude a 1-hour algorithm is safe to rule out acute myocardial infarction. There's no need to wait for 3 hours. Sensitive troponin cutoff of 6 performed better compared to the 99th percentile in view of lower follow-up mortality. Low troponin I values predict mortality in the general population. but further studies are needed to test the best cutoff for each troponin assay and to validate the 1-hour algorithm prospectively. Thank you very much for your...
Thank you very much. It's now open for questions. The gentleman on the first row, please.
Bruce Jansen, Cardiology News. That was a dizzying quantity of figures. Let me make sure I understand. So if 47% of patients were in the gray zone, would it be fair to say that using the 1-hour algorithm, 53% of patients could be ruled in or ruled out within 1 hour? 53%?
You're right. So after 1 hour, we could rule out and discharge 40% of all patients, but not 60%.
Lady on the third row.
Crystal Fenn with MedPage Today. I wondered if, Dr. Williams, could you give the U.S. perspective?
Well, it's interesting data. It would be nice to sort of compare data sets across many regions of the world. The one thing that is very striking is the age of this particular study. The mean age was actually quite young, if you look at it, compared to the patients that we're seeing in the United States, who are more around mid-63. Not sure that that would change the results, but the comorbid conditions that increase the troponins, whether it's sepsis, renal failure that we see in the United States, might make it important to focus on that delta that you showed of 12 nanograms per liter.
And he talked a lot about the European guidelines. Could you put it in context with the U.S. guidelines, how this fits?
Well, as you know, each set of guidelines is given at a time when there's sort of a moving target in terms of data like this. It's good to have the additional information that will inform future guidelines. So I look forward to seeing more data and more rapid rule-outs. I think it'd be very helpful in terms of the cost of medical care, particularly in our ERs in the United States.
Any other questions? Dean?
Well, I'm the ESC Press Chair, Steen Christensen. I just would like to inform the journalists that we have two experts as spokespersons from the ESC, and that is Dr. Lene Holmvang and Dr. Hooper, that are here on the first row. So if you want to discuss some of this afterwards, I know often that the presenters are very busy. They're rushing up to present their results. You can have comments also from these two experts. Thank you.
Well, with this, we close this